So, thank you very much, first of all, for coming along today to one of a series of staff roadshows that I've been doing. Apologies, first of all, I had planned to do these first week in April, but circumstances got in the way and I couldn't, so this is the first chance I've had to do that. So you're the fourth one I've done today, so hence my voice is starting to sound a little bit husky. So I do apologise for that in advance as well, but I hope you can hear me. So what I'm going to go through today is a little bit about our new organisation, which, as you know, came into being on the 1st of April this year. A who's who about our operational directorate structures that will probably concentrate more at the divisional level than it will down at the absolute directorates, but there'll be one or two in the audience that's going to see your name up in print in a minute or two. An update on where we are with Path to Excellence and some feedback and reflection on some of the items from the 2018 staff survey. And it's almost too late because the closing date is the closing time and dates today at 5 o'clock for staff governor elections, but I'll run through that briefly at the end as well, if that's okay. So as I said at the start, I'm happy to take any questions as I'm going through this, so please just catch my eye, raise your hand or do something else polite, and I'll try and answer that as best I can, but I will be repeating the question to make sure that those elsewhere can hear it first, all right? So you now know, I hope, that as of the 1st of April we're now known as South Tyneside and Sunderland NHS Foundation Trust. That's been the culmination of quite a lot of hard work and effort by a large number of our staff, some of which may not be necessarily seen to everybody. A lot of the due diligence, the governance stuff in particular goes on behind the scenes to get us to this point in time. But we're across that threshold now. There are one or two bits of the process we've still got to finalise and complete, and I'll talk about that in one or two of the later slides. But for now, we have now an operating licence as South Tyneside and Sunderland NHS Foundation Trust. New exciting chapter for us, hashtag One Team, One Trust. I know for some of the sessions I've done this morning at places like St Benedict's, the community ones I did yesterday at Palmer and at Clarendon, a number of staff have been through a number of these changes that have been tupied all over the place. I think the record we had yesterday was 6 or 7 times in the last 10 years. So although change is an inevitability with us at the moment, I am hoping for those staff in particular they get a degree of stability for a wee while at least to settle down into the new or newer organisation. So we ended up tupping across last year 8,000 staff into the organisation. Quite an effort for our HR teams and others in the organisation to do that, but we've done it. So a quick reminder, we are now providing community healthcare services to the populations of South Tyneside, to Gateshead and to Sunderland, acute hospital services to the people living in South Tyneside, Sunderland and parts of North Durham, and specialist hospital services to a wider regional population, with people coming to us from all over the northeast and beyond. So the Eye Infirmary is taking patients recently from Grimsby, for example, as well. So our reach has extended beyond the boundaries of just South Tyneside and Sunderland. And some of the specialist work in particular, I don't know if this presser works, I'll try it. Does it? It always does. Audiology, bariatrics, cardiology, head and neck cancer and surgery, haematology, level 3 neonatology, neurology, ophthalmology, orthodontics, renal medicine, spinal services, urology and vascular. And as of yesterday, was the 1st of May yesterday? It was the 1st of May yesterday. As of yesterday, we are now taking all the major arterial work or vascular work from Durham into Sunderland. So we're now one of 3 hubs for vascular surgery in the northeast. That's Sunderland, Middlesbrough and Newcastle. There'll still be a service left in Durham, but the major work will come into Sunderland. And I think we had our first patient yesterday, our first resident of Durham transferred yesterday. So vascular is now centralised in the northeast in 3 main arterial sites. So a little bit about the trust. Most of this you'll hopefully know. Population South Tyneside, 150,000 people. Sunderland, just under 278,000 people. Together 430,000. So it's quite it's a size and scale now with that population. Patients, around about 97.3% likely to recommend our services, and we've got a combined trust turnover of £550 million. Just to put that into context for you, that's probably about the size of County Durham and Darlington, probably about the size of Northumberland, and about 60%, I think, of Newcastle. So Newcastle's now above £1 billion spend, one of the biggest in the country, and employs, I think, about 14 or 15,000 staff. So they're a step again, a magnitude again beyond us. So we have increased our size clearly to 550 million, but that's just some comparisons with local organisations. Now, the one bit of the process we haven't completed and couldn't complete before the 31st of March is appointing our Council of Governors. That process has started. It will involve some elections on the basis we've got some competition for some of these posts, and we anticipate that will be complete by about August this year at the latest. The new constitution, which was drawn up by the previous two sets of councils of governors, means we're going to have 26 new governors in the, or 26 governors in the new trust. 15 of those will be public. We've abandoned the previous distinction we had between public and patient governor constituencies. We now just got the public constituency, of which there'll be 15. There'll be 6 staff governors. I'll come back to that a little bit later in the session, and there'll be 5 appointed governors. The appointed governors will be from the local authorities and from the universities in particular. That's pretty standard that most organisations do have appointed governors. The advice we got from the regulators in the run-up to the 31st of March was that councils of governors, in their eyes, and it's not an exact science, are most effective when they're somewhere between about 20 and 25, 26. So we're just outside that, but not significantly so. Northumbria, I'm told, have something like 70 governors. But that guess probably reflects their population and their geography, in that they've got people in Berwick, Rothbury, Alnwick, and almost everywhere in between, so to speak. So that's the bit we can't complete just yet. We will have to go through formal elections to appoint people to those public and staff slots. And if you move over to the top right-hand slide, we've got 22,000 members now of the Foundation Trust, 8,000 members of staff, and 14,000 public members. And they'll be the people, those members, that will vote for people to come on to the Council of Governors. So if you're a member of one of the 14,000 public members, you get to vote for the public constituencies, depending where you are. If you're one of the 8,000 staff members, you get a chance to vote for the 6 staff governors, again, depending which classification you're in. So that is a formal election process, and it's the person who gets the most votes gets appointed to the Council of Governors. So it'll take us a few weeks to go through that. And the closing date, I think, for governors is, certainly for staff governors, is today. I know we've got quite a lot of interest from staff governors. I'm not necessarily sure about public governors just yet, but I'm hoping we'll have quite a lot of interest for the public governors as well. I know we had very active governors beforehand. I know Marian's here with us today. She was a governor in South Tyneside, and similarly we've got governors in Sunderland that I know will probably want to stand again. So there's lots of stats we can give you about the new organisation, but just here's a couple. Diagnostics, we're now going to be doing something like 170,000 diagnostic tests. That will be growing. That's an area I think we can anticipate we're going to be doing more of these in the future. And over 225,000 emergency care attendances every year, split roughly 170,000 in adults and 53,000 in paediatrics. So we're going to be, in that sort of size and scale, we're going to be a big organisation. Those numbers for emergency care attendances are probably right up there with Newcastle and with the Emergency Specialist Centre in Cramlington. And regularly our numbers are exceeding Newcastle now. Remember, Newcastle's a major trauma centre, so they would, and we would anticipate more ambulances going to a major trauma centre. But actually I think more will come to our trust on a regular number of occasions compared to Newcastle. NSEC's probably just slightly bigger. So we're busy and busier as a result of combining our 2 or 3 or 4 emergency departments, depending how you count places like the Eye Infirmary, etc., etc. So quite big or bigger now in scale and scope. Main locations, these will be familiar to you, hopefully. South Tyneside, the Eye Infirmary, the Royal Hospital Durham Treatment Centre. For those of you who don't know, that's in Belmont. As you approach Durham, right beside I think the BMW garage, the Mini garage and the Skoda garage. For those of you who know that part of the world, you can't miss it. The Palmer Community Hospital, Clarendon, Sunderland Children's Centre, the Elmville unit at Monkton Hall, St Benedict's Hospice, and clearly Haven Court, which is part of our hospital site here, but we treat it as a separate service in that sense. Plus, it says hundreds of community venues and home visits. Well, I think we've got 62 different community venues, but clearly home visits can take us to almost anywhere across the patch. So we've got quite a broad spread of hospital and out of hospital facilities and functions in this new trust. So I'm not going to dwell too long on this one, because certainly the things like the vision and the values have been prominently displayed across both organisations for some time. The bit that's new is the bit on the right-hand side, which is this section here. You probably can't read it. That's not deliberate. It is in some of the handouts we've got down here for you at the front. That's more about the behaviours. And we did feel it was important that, I'm not trying to repeat previous issues, but we did think it was important we started the new organisation with some form of framework by which we can set some standards to try and make sure that everything we do adheres to those standards. It's difficult to criticise people for poor behaviour. Actually, if you haven't got a benchmark to measure that against, similarly it's difficult to give people credit for good behaviour and things they do if you similarly haven't got a benchmark. So we've now tried to codify that. I think in South Tyneside previously you used to have a compact, I seem to recall a few years ago. It's not dissimilar to that. A lot of the things will be very similar to the things you've seen in the compact previously. But essentially at its core is a recognition that actually we're now one team, and everybody should be pulling in the same direction. And absolutely we must have patients at the forefront of everything that we do. But it's setting down some benchmarks. I haven't got necessarily time today to dwell on each one in detail. There'll be nothing in there, I hope, that surprises anybody. Please take it away, digest it, discuss it amongst you and your teams. What we are very keen, though, is that people in our organisation now feel empowered if they don't observe other members of their own team or other teams adhering to those sort of behaviours, so that you feel empowered to challenge them. Now, that doesn't matter whether it's me or whether it's anybody else. So if somebody sees me leaving today, going back to my car, opening the window and chucking off my rubbish out on the car park or on the tarmac beside me, I want to feel confident that you lot won't feel in any way, shape or form embarrassed or anything else about coming up, knocking on the window and say, hey mate, pick it up. So you're not going to be criticised for doing that by anybody. You're actually going to be applauded for doing it, because you're adhering to some of the behaviours and principles that we want within the organisation. So please take an opportunity to digest that in a little more detail, because that's probably a bit newer than the values and vision, most of which you've seen sometime previously before. And that's on page 4 and 5 of the staff magazine, of which Lauren's got some copies down here at the front. That's the executive leadership team, again, most of whom I hope will be familiar. You can probably tell which ones have been done professionally, but I'll leave you to judge who that is. I'll not dwell on myself. Kath Griven, starting in the middle row from the left, our Director of Human Resources and Organisational Development. Melanie Johnson, Director of Nursing, Midwifery and Allied Health Professionals. Shaz Wahid, new Medical Director from 1st of April. Julia Patterson, Director of Finance. Peter Sutton, Director of Planning and Business Development. Liz Davis, the Head of Comms. Sean Fennick, Director of Operations. Andrea Hetherington, Acting Director of Corporate Affairs. Andy Hart, Director of IM&T. Alison King, Director of Performance, and Steve Jameson, Director of Estates and Facilities. Most of those faces, I hope, are familiar to most people in the organisation. Now, that's the executive team. Clearly, the top left indicates the executive team has reporting responsibilities to the Board of Directors, and the Board of Directors ultimately to the Council of Governors. Now, it does mean, because we haven't got a Council of Governors at the moment, we are unique. We're the only foundation trust in the country that hasn't got a Council of Governors at the moment. Everybody else has. Ours will take, as I said, probably till about August to get appointed. And one of the functions of the Council of Governors is to appoint substantively the chairman and the non-executive directors of the new foundation trust. So the board of directors at the moment essentially is still interim until we've been through that formal appointment stage a little bit later in the year, although they have got the responsibility of carrying out the full functions of the foundation trust through the license that's been given to us already. One of the other responsibilities of the Council of Governors is actually to decide to approve a recommendation from the directors about the appointment or the dismissal of a chief executive. So I will also get dragged into that conversation as well in due course. But that's the executive team for now, and those are probably the people you'll have most familiarity with and probably most contact with going forward. Now, dipping down a little bit, Sean Fennick, as many of you will know, Director of Operations, still doing a little bit of nephrology work. He's a consultant nephrologist by training. We've now got 7 operating divisions across the new organisation, starting with Community here. Each of those has got a divisional director, so Community is now going to be headed up by Joanna Clark, who was formerly one of the director managers at City Hospitals. Clinical support functions, all our radiology, pathology, pharmacy, etc., will fall to Jackie Butterworth. Family care, obstetrics, gynecology, paediatrics, amongst others, will be Vicky Mitchell. Surgery will be Lorraine Nelson. Theatres, Anna Hargrave. Urgent emergency care, Angela Wadmore. And last but not least, medicine with Kerry Bentham, who is here with us today in the audience. We've introduced a substructure beneath that called Associate Divisional Directors now, partly with one eye on succession planning for the future, because we've never had that sort of interim step. We're a bigger organisation. We've got to also look at the size and scope of these roles, but we've got 3 intermediate tier associate directors here, and these names will broadly be familiar to most people in the audience: Bronya Fleet, Helen Turnbull and Lee Whitfield, and they're working to the respective lines up above. And this is a slightly new issue to introduce formal heads of nursing now across the whole organisation. So Mel Milburn doing that on behalf of Community Services. Sharon McDowell, who's with us today in the audience, covering clinical support, family care, surgery and theatres. And Karen Sheard, who's also with us in the audience today, picking up urgent emergency care and medicine for your sins. So that's a slight departure to do that consistently across both the previous organisations, but we've now got a head of nursing post identified supporting those divisions, and clearly there's a number of directorates beneath that as well, which I haven't got time to go into today. But that's the way the sort of top end of our divisional structures look like. So 7 divisions split that particular way. So one team, one trust. Some practical issues now, just to dwell on for a second or two. It would be easy, might have been easier, some might say, had we started the 1st of April and we just did everything, changed everything in one fell swoop and got all the documentation, the signage and everything sorted from day one. We haven't taken that approach, partly through cost, partly because it's just need to be pragmatic about it, not change everything absolutely once where it doesn't need to be changed. But you're going to increasingly see new signage. We've done most of the major signs on the hospital sites, already been identified with a new trust name on there. The branding is this sort of stuff here, and the colour schemes on that, you'll see that repeating on almost all our documentation from now on. The intranet's being revamped, as is the public website. That will improve, has improved already, will improve further as we get into that. There's a dedicated email for any queries you may have. We've updated the frequently asked questions on the intranet. Hopefully that covers most, if not all, of the questions that people have. We are going to be working now towards a new email system, and it's going to be NHS Mail 2. That's probably going to be an autumn task. It's a bit difficult and tricky to transfer everybody from their current email addresses into NHS Mail 2. So that's why that's probably going to be an autumn task. There's quite a lot of logistics involved in doing that for 8,000 people. to get that done. We've had some concerns, it would be fair to say, about NHS Net and NHS Mail previously. That's one of the reasons why we haven't moved on to that. But more and more the rest of the country is moving on to that now, so it probably makes sense for us to move across. But we won't have that certainly in place. Well, we haven't got it in place now. That's likely to be the autumn by the time we get that sorted. And then new ID badges as well, similar issues. We're currently having them printed. We'll share more concrete information with you in the next few weeks. Again, they'll be progressively introduced across the organisations. But we're going to try, obviously, and go to one ID badge at some point where that will give you access to almost all the bits you need on the various sites and properties that we own. So I, for example, now have a single badge there, but on the back of it I've got a little tag that allows me to get access, a little white tag like that. If you can see that, you probably can't see that on the camera. That allows me access into everything in South Tyneside now, but eventually we'll go to that being properly embedded on a single card. But that takes a bit of time and a bit of resource to do that, but you'll see that happening as we roll that out in coming weeks, with a single ID card badge being the ultimate destination. So we haven't decided to try and do everything for the 1st of April. It would have been impossible to do so. We're just going to phase that in. The shuttle bus. This was an issue that was raised, as you know, as part of the Path to Excellence and the service review process, about concerns from staff about being able to, if their roles are being moved between the various hospital sites, about the ease of doing that and the pressure on car parking spaces and everything else that we've had. So we put on a shuttle bus from the 1st of April. It's been running for 32 days already. It's been doing around about 35 journeys every day between the two sites. It's been gradually increasing throughout April. And I have to tell you, at this point, we've been pleasantly surprised by the interest in that. It's been much better than we thought. So a lot of people are using it, and I have to say people are using it both ways. It's not all people transferring or travelling from South Tyneside to Sunderland. It's people coming the other way as well. And it's going to be one of these things, if people don't use it, we won't provide it. We know already the 5:30 slot, which apparently that's the last trip of the day, both ways. That's not been used at all, I think, in April by anybody. That was a bit of a surprise. We thought staff would be finishing work 5-ish. We'd want to get on the bus about 5:30 and get back to either Sunderland or South Tyneside in a reasonable time. But I don't think we've had anybody use that 5:30 slot already. So if that continues, we won't continue with that. We'll look for another timing or change the timings. We'll let that run for about 3 to 6 months, I think we've said so far. Then we'll get a proper body of evidence rather than just 32 days and see what really is coming from it. But based on the first 30 days, the uptake's been greater than we thought. So if that continues, then clearly that's going to be good. There are some, for those, how many of you have used it? Blimey. When I did that this morning, I've got 2 hands up, didn't I, somewhere else? Excellent. Mainly going that way or both ways? Excellent. So have you had a form to fill in on the bus asking you your thoughts already? Tremendous. I hope you've taken the opportunity of doing that. Before you raise it, yes, we will be getting Wi-Fi on there. It's been raised several times already. And staff tell me they want Wi-Fi because they're so keen to work on the bus between sites. Perfectly reasonable. If you've got any further comments on that, let us know. There's more forms here today if you haven't done that. Again, I reiterate the point. If people use it, it'll continue. If they don't, it won't. So, but we'll leave that a reasonable period of time to evaluate properly before we make any decisions. Yes, Marion?
Can I ask who provides the service?
Do you know, I can't remember, Marion, what the answer to that is. What provider we went to in the end. I know it's some of our ex-employees who are driving the bus, who've retired. I can't remember the name of the provider off the top of my head. We'll confirm that separately for you.
It's not a stagecoach company or Nexus. It's us providing it.
Oh yes, it's us. Yeah. Gosh, yeah. Yeah, we're paying for it. I don't quite know where we got the bus from. That's probably what I was driving at. But again, if it's being used, it'll survive. If not, it won't. But so far, based on the first month, it looks like it's going to be more popular than we anticipated, which is good.
Do you envisage that it'll be used for patients or relatives in
Not
the future, or is the plan?
No, it's staff only at the moment. I think it's a bigger step to start talking about patients. There's other discussions going on with the travel companies and the local authorities about patients and visitors getting greater access between Sunderland and South Tyneside. This is for staff only. In a way, we want the local authority and other partners, including the CCG, to make some decisions about that. And that, as you know, is a more tricky one for us to influence. These bus operators are commercial operators. It's either got the footfall or it hasn't. If it hasn't, they won't provide it. So that's a bit more of a tricky one. Okay. Right, that's probably enough of that. Path to excellence. So phase one, phase one, that's maternity, paediatrics and stroke services, are now moving more into the implementation phase. We've started the HR consultation now with staff, planning towards those implementation for maternity in particular. Paediatrics is probably going to be a little bit later in the year now. We think there's some internal issues to get over with paediatrics, but maternity certainly is the one that's we hope is going to land a bit sooner. The exact dates to be confirmed on maternity, because we have been having a bit of discussion the last couple of weeks about what's a reasonable period of notice to give mums-to-be about some of the choices they may face about where they want their baby. We felt that just saying actually doing it in 4 weeks' time, whether we're ready to do it or not is another matter, was probably too short. So we've been arguing and debating how long that period should be to give people a chance to say, look, I don't want to have my baby in Sunderland or South Tyneside. I want to go to Gateshead, Newcastle or wherever, and allow them to do that, to handle that transfer sensibly. So that's been partly the debate on that. As soon as we've got a formal date on that, and it's likely to be the next few months, now we'll confirm that. That's why it says to be confirmed. But stroke changes, I think it would be fair to say they've been highly successful in improving patient outcomes for our acute stroke services, now rated at level B, 1 point away from level A. And the NHS, as part of the sentinel stroke audit, scores stroke services A to E, A being the best, E being the worst. So in 2016, the service in South Tyneside was rated at E, and the service at Sunderland was rated at D. So some of the lowest in the country, never mind in the region. So 2 years on from that now, here's some of the things that have changed with stroke services. So there's about 7 or 8 of these. I'll just talk about 1 or 2 if I may. Patients being scanned within an hour. Previously 22% of patients in South Tyneside got that or received that. Sunderland 41%. After the change, 70% now getting it. Average time for a scan, it was 2 hours and 1 hour 12 minutes. It's now 35 minutes. And there's some even more marked ones on this slide. Patients directly admitted to a stroke unit within 4 hours was 6% in South Tyneside in 2016, Sunderland 72, that's now 74 for both. And then the third one down, eligible patients given thrombolysis, so-called clot-busting drugs, was 9% in South Tyneside 2 years ago, in Sunderland 63, that's now up to 85%. So not only have South Tyneside's residents received an improved service on those scores, so have Sunderland too. And that's what's resulted, those aggregated up have resulted in us moving from D and E level performance up to level B and 1 mark away from an A. That data I think is the data to the end of December. That's the last quarter that's been published. We'll wait and see what the latest quarter to March actually gives us. Phase 2, as you know, we've slightly changed the way we've been doing phase 2 engagement with staff. We published recently an updated draft case of change and a working list of ideas for phase 2. And we've done this time to make sure that some of the concerns that were raised last time around staff not knowing what was going on in their particular areas, paediatrics, maternity in particular, less so in stroke, but still relevant. This time we're going to make sure that people have got the opportunity of influencing some of these working ideas before we get to going out to pre-engagement and proper consultation in due course. So all I can talk about today are some broad concepts because they haven't been worked through properly yet or tested. There's 4 of them up there on the slide. One of them, the first of which is making sure we've got continued 24/7 access to urgent or emergency care for both local populations. And as you know, there have been some concerns from a lot of the residents in South Tyneside about the downgrading of the hospital, losing its A&E service and a range of other issues as well. So that's there to partly make sure we make the point in public there's going to continue to be emergency care and access for patients in South Tyneside and Sunderland in the future. Separating where we can planned operations from emergency surgery. This is what they've done in Northumbria with the creation of the Specialist Emergency Centre at Cramlington. They've centralised all their complex emergency work in Cramlington, which means that the other hospitals around it, so your Hexhams, your Ashingtons, your North Tynesides, your Wansbecks, not only are they providing care closer to people's home where that's relevant, but they've probably got more of a focus on planned operations now rather than emergency. Now, it's not so easy for us to do that, but it's something the teams have got in mind and want to try and deliver that wherever we can. We don't have a huge problem with cancelling patients on the run-up to surgery, and worse still, cancelling them on the day of surgery, of planned surgery, but we do have some of it. And of course, whilst our numbers are quite small compared to others, if you're one of those patients or the families of those patients that get cancelled after you've waited for 4 months, 5 months for your hip to be done or your knee to be done, I just use orthopaedics as an example, then that can be quite devastating for that family. So we want to try as much as we can and make sure if we give you a date for planned surgery, we can almost guarantee it's going to go ahead. You do that by separating out your emergency from your planned care where you can. Another working idea is creating a centre of surgical excellence down here in South Tyneside for planned care and the development of an integrated diagnostic and imaging centre. If there's one thing I think both our main hospital sites are going to face is increasing demand for diagnostics and imaging. That's an absolute certainty. So we've got to partly predict that and build some of the capacity in where we can. And the last bit is almost a philosophical point now about trying to provide much more care closer to people's homes rather than always asking them to come into hospital for their care. So those are some of the working ideas that are coming out of the team so far on phase 2. Now the bit in red is important because we've been told clearly by NHS England that we cannot, or the CCGs cannot proceed to consultation unless we've got any capital investment items associated with the scheme, the phase 2 items, phase 2 issues identified in advance, and we have not got that at this stage. So we do not have any of the capital tied down at this stage. So at this stage we couldn't go to consultation. The worst thing we could do is go to consultation, get a result, so to speak, and say to the public we now can't implement because we ain't got the money. Capital is scarce in the NHS at the moment. About a year ago, all parts of the North East were asked to put forward their capital schemes, and there was a prioritisation process that went on to prioritise those. So all the foundation trusts, all the CCGs put schemes forward. We put our Path to Excellence scheme forward, even though at that stage we didn't know what the capital requirements were. But if we hadn't put anything forward, we would have got nothing. That's true. So we had to second guess a little bit what was coming out of, or likely to come out of, some of this sort of stuff, to at least make sure we've got ourselves on the scoreboard. We did that. Path to Excellence and Vascular, which I mentioned earlier on, were ranked in the top 4 schemes in the region, top 7 schemes in the region, we were ranked about 4th. The 2 schemes above us were a development in mental health at Northumberland, Tyne Wear and Newcastle, big development, about 50 odd million. And the other one was congenital heart disease at the Freeman. So those were the first and second, and then the Path to Excellence and Vascular were the next 2. The only scheme that got supported by the NHS was the mental health one in Newcastle. The others weren't supported because there was not the capital to do it. Now, the reason we haven't got the capital is partly because the NHS has been using capital resources to bail out revenue for quite a few years now, because the pressure has been on all hospitals spending, on day-to-day spending. So the NHS has been moving money from capital into revenue to help with that. And they've also had to dip into their pockets to finish the scheme in Liverpool University Hospitals that's been featured on TV recently after the collapse of Carillion. Because Carillion were building that, and actually when they went kaput, then it left a half-finished hospital building in Liverpool, so they've had to step in and complete that. And I think the sort of costs with that were over 200 million to get that complete. So that's meant that other parts of the NHS have had less flexibility on capital. So that's why we didn't get our schemes supported. But because we want to try and keep this to timetable, we have therefore been looking at other sources of funding for these schemes. And in particular, we've asked the local authority in South Tyneside and the local authority in Sunderland if they'd be prepared to give us the money. It is a loan, but it would be a loan from the NHS. It's the same way this works. And we'll have to have a definitive answer on that in the next few weeks. And if that answer is yes, then we can proceed, subject to 1 or 2 checks with NHS England, to consultation. If the answer is no, we can't. So the money is becoming a bigger and bigger issue. We'd be asking South Tyneside for about, I'll come back now in a second, for about 35 million, because most of the capital investment will be on this site. Certainly if we do a surgical centre or an integrated diagnostic and an imaging centre, less so in Sunderland. But we need to ask, we've asked that question, we'll see what response we formally get back from them. Yes, Marion, sorry.
You've said you've asked the local authority
Yes.
if it would be a loan from them.
Yes.
Where are they getting the money from? Because they're in just as much of a dire straits, as I'm led to believe, as the NHS. The local government are looking at cutbacks in their services. So
Well,
get that.
Sure, I'll repeat that question just so the audience elsewhere can hear that. So Marion's asking the question about the local authorities are under the same, if not more, pressure than the health service. So where are they going to get the money from? That's, as I understand it, Marion, that's absolutely true about their day-to-day running costs. But I do understand our local authorities do have quite substantial cash reserves. That's different, cash reserves that they can use to support some of these developments. Now, they might come back still and say, no, we can't do it. We don't know definitively what the answer is, but we're asking the question. Okay. So next steps, this is slightly out of sync now. We've been holding a whole series of staff engagement events towards the back end of March. Around about 180 members of staff have turned up and shared their views with us, which is great. We've been doing a series of public awareness roadshow activity, working with Health Watch, one of the statutory bodies. We did that in March. We've had a visit from the clinical senates. Clinical senates come and test your options, your working ideas compared to national and international best practice to make sure, again, we've left no stone unturned and we've got something that makes sense clinically. We've been doing some stakeholder engagement events during April, and all the feedback from all these events is going to be considered now as part of the pre-consultation business case. And if everything goes to plan, and we get the capital secured, and we get, that's a big caveat at this stage, we get the capital secured, then at the moment, then we'll be able to go to consultation late summer, early autumn. And if you're asking me, it's probably more autumn than summer at this stage. I suspect that will probably get nudged back a little bit. And if that went to consultation in autumn, subject to that going smoothly through consultation, and that is again an assumption, that would probably mean we wouldn't be able to implement anything probably until spring 2021 at the earliest, possibly even a bit beyond that. And just for the very nature of these things, by the time we finish that, we'll probably have to go back and revisit phase 1 again. Who knows, a bit like painting the fourth road bridge. So that's the next steps on Path to Excellence. Right, NHS Staff Survey Results 2018. Now remember, this is a survey that you completed last September in your own individual foundation trusts. So we've tried to amalgamate some of the issues where we can. The one you'll do this September will be for the new combined trust, so it may or may not change in due course. So firstly, a thanks to everybody who completed the survey. We are seeing continual improvement in our response rates to these surveys, so more staff are completing them. We don't need 100% of staff to complete them for it to be a representative of the organisation. Once we get to sort of 30, 40, 50%, you've probably got a pretty good cross-section of both organisations as it was at the time, but the more we get done, probably the better. Over 90% of our staff feel that their role makes a difference to patients. Now, if you just reflect on that for a second, that's great. But what about the other 10? That's 800 people out of our 8,000 employees that you might say, if you read that, don't think their role makes a difference to patients. Now, we'd quite like to know what that sort of stuff's actually about. It's difficult for us with things like the staff survey because you know it's anonymous and you know the sort of feedback we get is quite generic. So it might say, your nurses are telling us that, or your doctors are telling us that, or your admin staff are telling us. It doesn't really identify who and where. So it's a tricky one for us. We'd like to explore that and find out where and why, so we can do something about it. But we aren't able to pinpoint accurately where that's coming from. So it inevitably just ends up being quite generic by its very nature. Overall, more staff recommended as a place to work or receive care. Again, that's an important indicator for me, because if you as our staff aren't happy about recommending your own hospital services, wherever it is, for the care of your own family, then I think we're getting something wrong, aren't we? Again, that's an important indicator in with those results. Core strengths: more staff in both organisations feeling satisfied and valued at work. That's great. More staff feeling they're treated fairly when involved with incidents, errors or near misses. More staff feeling their training, learning and development needs are identified at South Tyneside, and more staff feeling able to report incidents of physical violence at work. And there are some examples now of physical violence not just being about patients and staff. We're getting 1 or 2 instances where it's staff and staff. Not significant, but it's just crept onto the numbers a little bit as well. So go back to behaviours, the stuff we put in at the start, and just reflect on that for a minute. Not significant, but it's just creeping in 1 or 2 occasions. So there's some core strengths in both and individual organisations as we look backwards from the previous surveys that I think we can build on in the new surveys. But South Tyneside scores above average in 4 out of the 10 key elements in the National Staff Survey. So Sunderland's 5 out of 10. The question we're asking is, how do we get to 10 out of 10? And whilst we do okay, probably better than average compared to national organisations, we do not do as well compared to 2 or 3 local organisations. So Newcastle, Northumbria and Gateshead all probably perform higher or score better in some of the key questions coming out of the staff survey. And we'd like to know why. Now bear in mind this was done a year ago, September. We had lots of change going on in the organisation around Path to Excellence and the run up to the merger and all the stuff we went through then. That could be an issue. Of course it could be an issue. But those trusts have probably consistently scored higher than our 2 individual organisations and our combined organisation now over the previous 5 or so years from recollection. So again, we need to try and get underneath the skin of that a little bit and find out why. What are they doing where their staff think that they're more supported, they get more access to training and development, they feel more valued, whatever the actual indicator is, we'd like to try and get underneath that. And as a consequence of that, one part of that is thinking about how we improve our overall staff engagement going forward. So there is here a short comms and engagement survey. It's on the intranet, but there's a hard copy here if you want to complete one. It'll take you a couple of minutes, about 20 questions. It's relatively straightforward, which does close tomorrow. So again, we want to hear some of your views about how we can improve sessions like this. Some of the magazines and the pamphlets we put out, some of the other briefing sessions we do to make sure it's getting to the right audience, you're getting the right content, you're getting it frequently enough, etc., etc. So please take the opportunity today, if you haven't done one, of filling one in and either leaving it here today, be fab, or sending it in separately or doing it via the internet, even better. But that closes to tomorrow, and we do want to hear from you. So I'll finish before taking any questions with staff governor elections. Now, unfortunately, this closes in about an hour and 15 minutes. So if you want to be a staff governor, you're going to have to move quick. We've got 6, 2 clinical acute, 1 clinical in the community, 2 non-clinical, and 1 medical and dental. So those are the constituencies that you can apply for if you wish to be a staff governor. As I say, if there's more than 1 potential appointee, we get into an election. If not, they get appointed unopposed. That's why it'll take a little bit of time to work through this. And staff governors, and I know there's a few of you in the audience have been staff governors already, I think perform a really important role and do add value to our Council of Governors. I particularly like the fact that I think sometimes members of the public come perhaps with one or two preconceived ideas about how and why we do things in the health service the way we do it. I think it's really quite powerful when you get nurses, doctors, admin staff, whoever it happens to be, actually just saying, no, that's not the way it happens, or this is why it happens in that particular way. It can be very powerful, and they do add value. So I hope we'll get a good deal of interest for that. If it's too late for you this time round, there will be another opportunity because these things go through a cycle, probably every 3 years or so. So you'll have an opportunity, if not this time round, for doing it next time round. But we'd be keen for as many people as possible to take part in that. And we've tried to decide to define the constituencies to reflect broadly the makeup of the new organisation. So something on there specifically for community, something there for medical and dental, clinical acute and non-clinical as well. It's only 6, but actually those 6 people can be quite powerful, I think, in the Council of Governors. If you are interested, let Sylvia and Rhys know, and we'll put you on the list of interest, potential interest for next time, and then we can pick that up again then. Right, I'm going to pause there and see if we've got any questions from the floor. I'll just grab a quick mouthful of water, if I may. Yep.
I work in radiology, and in the last couple of weeks we've had a lot of not interest, but being informed, not directly, with regards to clinics moving between the 2 sites, and South Tyneside patients being seen at Sunderland and vice versa. And there seems to be a lack of appreciation of the amount of work that's involved to make sure that everything that's needed is at the correct site, like so the image is being transferred, it's being transferred, which is increasing the amount of work that the teams are needed to do. So my question was more around IT infrastructure.
Yeah.
And when's that going to be in place to allow us to support those clinical teams?
Yeah.
Because it gets very frustrating for us when we
Yeah.
can't provide what's needed,
Yeah.
or we can provide it, but it doesn't perform as it should.
Yep. Okay, so this is a question about the movement of clinics between various sites and making sure, and I'm paraphrasing here, please tell me if I'm wrong, but trying to make sure we've got the right capacity in place to handle that, particularly IT and issues around that. Would that be a fair summary of the question? Okay, so there's two bits to this answer actually. The first is the radiography and radiology departments across the North East are looking now at how they make better use of technology themselves to make sure images in particular can get moved about our system almost anywhere around. And the PACS systems, as you know, we've got different PACS systems across the North East, which is a problem in itself. It would be great if we just had one. So I know the radiology teams are looking at that themselves. Second issue, I suppose, comes back to the global digital exemplar and the fast follower status and some investment in that technology as well. Now that's going to help South Tyneside put some of the things it needs in place to manage Meditech going forward. I know radiology won't necessarily be completely on Meditech, but certainly the rest of the systems will be around it. But you're not going to see the benefit of that properly until about 2021 at the earliest. So we are going to have a little bit of an interregnum until we can get there to put that capacity in place. Now, I don't know the specifics about what's being done in your own directorate, but we can make sure your directorate managers and teams, and I know they will because they're pretty clued up on this sort of stuff, are planning that stuff. But perhaps the most important bit is they're telling you what those plans are so you can see in advance. But you're right, there is some transferring already of sites, of clinics between sites. We want to make, as far as the patient's concerned in particular, we want to give them as much local access as we possibly can. There's no point in asking South Tyneside, Hebden or Jarrow residents to traipse all the way up to Sunderland Eye Infirmary, for example. If we can see them as outpatients down here in South Tyneside, it's much more convenient for them. So it starts from that principle. But I do agree we've got to put some of the backup in to make that work. But I don't know the specifics about your own department, but I can certainly make sure your senior team are communicating to you what's the plan and how we're going to do that over a period of time.
I think for us it's more that we're getting negative feedback from the clinical teams because it's perceived that we can't provide the service.
So you're being seen as the blockage, I mean.
Yeah.
Right, okay, fine,
and
okay.
we don't, I know there's a plan to put a bigger pipe between the 2 sites
Yeah.
to get better performance,
Yes.
but that doesn't help the teams at the moment. It's
No.
whether that's being communicated to those
Right, okay,
teams.
fine. Sorry, I've misinterpreted what you're saying. I beg your pardon. My fault. So that is something we can do something about, because that is something we can take away, make sure teams aren't pressurising you to deliver something you can't deliver until you've got the facilities in place. Absolutely. Yeah. But that just, we need to just manage. And I understand what you're saying, because I've heard it myself from one or two of the clinical teams. Just because they think they've got things sorted, they suddenly expect everything else is going to drop into place. That's not just true of things like clinical support. I could take it wider. Almost any service you care to imagine. Most of the business cases we see at exec team level are great, but quite often they forget things like facilities, car parking, and all the other stuff that goes with it. So all these things have got to be in place before we press the button and say, yes, we're going to deliver that service. So that is a message we'll take away. Lauren's making a note of all these questions, so we'll make sure they're filtered back. But that's the sort of thing I can speak to the clinical directors about in totality, and make sure they've got that message that actually all parts of the system need to be ready to rock and roll at once, not just bits of it. Good question, thank you. Any more? Yes, Marianne?
There's a lot of information there about the clinical services
Yes.
and changes that
Yep.
will come about eventually
Yep.
at some point. What changes have you in place for facilities and estates? Because now we're in one organisation
Yeah.
with two differences.
Yes.
Obviously, we've got choice.
Yes,
in
we have.
Scotland.
Yeah, well, you know the public commitment we made in the run-up to the merger.
Happy if you take them back in-house.
So the question that's being asked about what are our plans looking ahead for estates and facility staff in particular, given that there's choice up the road, or was up the road or is up the road in Sunderland. It's the same organisation now. So that's the gist of the question from Marion. So the commitment we made in the run-up to 31st of March still stands. When we're in a position of wanting to talk about what the future might hold for our estates facility staff, then we'll come and do that with you formally. There are no formal plans at the moment. We're still stuck to that. We're just getting over the 1st of April. Marion, when we're at that point where we think we've got something to talk to you about, then, and staff will be talked about clearly first, because they have a view in this, absolutely, about whether we do it or not. Choice has been successful at Sunderland. I know that, I've seen the figures, obviously. And I know the sensitivities about it from South Tyneside. You've articulated that, and so have your colleagues. So we'll do that in a planned way with you when we get to that point and we're ready to have that conversation. So I can't prejudge that because there isn't anything to tell you, because we haven't got a preset game plan. But we did say we would leave that discussion until after we got over the merger. We're a month into the merger. That won't happen, in my view, for a while yet. Okay? Yep.
Before you mentioned Meditech, I don't know, because we don't have it on this site.
No.
Do you have a plan time frame as to when we'll be getting it transferred here?
So the question was about Meditech and the planned timescale for getting it into South Tyneside. So yes, Meditech is coming into South Tyneside. It will be a little bit later on than the Sunderland development. Meditech's been in Sunderland for 20 odd years. So probably it will start this year, but it probably won't be implemented until 21-22. Okay, that's not a small undertaking, Meditech, I'm afraid. It's not so much the technology, it's the changes in working practice that have to work around that, and that's not a quick fix. But clearly it's going to be much more based around electronic information, much less use of paper. We've got an A&E department up the road at Sunderland that's virtually paper-free now. One of the first A&E departments in the country to do that. So that's sort of, that will cascade down to South Tyneside over the course of the next couple of years. And we've been able to secure GD fast follower status for South Tyneside on the back of Meditech in Sunderland. That's brought £5 million of investment with it. Sounds like a lot of money actually, but once you take off VAT and fees, actually you're not left with a huge amount. But £5 million nonetheless that we didn't have prior to this. We've got to match that with our own money, so we're going to find 5 million ourselves. That 10 million actually will be the investment pad for bringing Meditech into South Tyneside. You already use some of it, so the labs service we use in Gateshead through pathology, that's all Meditech based already and has been for a number of years. But for the wards departments and other bit, that will be a change in the way they work. in that system, and it is much more automated. And it just makes sense to do it once. It means that things like junior doctors that come and train in the two separate hospitals, when they move, and a lot of them do move between the two hospitals, they're familiar with the systems. I wish the rest of the North East was like that, but hey ho, that's where we are. So it's coming probably in the next two and a bit years. Okay? I'll come and ask you in 2 years' time how much it's changed your life, or changed the way you work rather than your life per se. But good question. Any more? You sure? Right, okay, well at 3 minutes to 4 o'clock, thank you very much for coming this afternoon. We'll be trying to do these Chief Executive Roadshows maybe 3 or 4 times a year now. We're going to step that up a little bit. So again, as part of the COM survey, it asks you some questions about timing. Without being derogatory, but I suspect we've probably only got a handful of clinical staff here today. So I'm hoping if we do them 3 or 4 times a year, we don't expect everybody to turn up at every event. But if we look at the timing of these and get them a bit more appropriate over the course of the year, I hope we'll get a reasonable cross-section of the organisation, if that's fair. So if you've got some views on that sort of stuff, please let us have them as well. If this time isn't convenient for you, you'd rather do early, late, middle of the day or whatever, then tell us, because we'll try and capture all those views as part of the survey. But if there's nothing else, thank you very much for coming and listening.
Thank you very much.